Hello, I am Donna Sheeler, nurse consultant for the DC Health Perinatal Hepatitis B program. Thank you for watching this presentation on A Case for Management of the Hepatitis B Positive Mother, a Cautionary Tale. This account represents an actual case discovered through my work as a perinatal hepatitis B nurse consultant. The names have been changed to protect the privacy of the affected mother and infant. Meet Nora. She's happy. She's beautiful. She's fun-loving. But Nora is infected with the hepatitis B virus. You might wonder how this happened. We don't know for sure. But let's examine the factors that may have contributed to Nora being infected. Nora's mother, Mary, started out prenatal care at 12 weeks gestation. She had been told before that she had hepatitis B from her previous pregnancy. Her doctor performed the recommended hepatitis profile test at 16 weeks, which showed Mary as hepatitis B positive. All other hepatitis profile components were negative. Mary had 14 prenatal visits and saw at least 4 different doctors in the practice, with her main doctor seeing her at least on 10 of those occasions. Everything seemed to be going great. At 36 weeks gestation, Mary's doctor ordered the usual panel of labs along with a hepatitis profile. It just confirmed that Mary was still hepatitis B antigen positive again. No other hepatitis labs were done. Mary was not referred to a hepatologist or infectious disease specialist. Baby Nora was born at a healthy full-term weight. She received hepatitis B immune globulin and hepatitis B vaccine within 12 hours of birth as protocol for an infant born to a hepatitis B infected mother. Baby Nora had the rest of her subsequent hepatitis B vaccines by her 6-month visit. Her post-vaccine serology test was completed at age 15 months. Nora's post-vaccine serology showed that she was hepatitis B surface antigen positive. Nora was infected with the hepatitis B virus. The pediatrician ordered liver function test on baby Nora. It showed elevated ALTs and ASTs and a below normal ALK. She was referred to a pediatric liver specialist for continued care. Nora's mom, Mary, received timely early prenatal care. Mary was appropriately evaluated early for the hepatitis B surface antigen. Baby Nora was given appropriate prophylaxis of Hb and the hepatitis B vaccine within 12 hours of birth. Baby Nora had all hepatitis B vaccines by 6 months of age. So how is it that Nora became infected with hepatitis B? We may never know for sure. Even with timely post-exposure prophylaxis for babies identified born to hepatitis B surface antigen positive mothers, it is estimated that about 950 infants in the United States are perinatally infected with the hepatitis B virus each year. Let's explore the reasons that baby Nora could have been an increased risk of exposure. 3 factors that have been known to increase the likelihood of perinatal hepatitis B transmission are high hepatitis B viral load of the mother, especially at time of delivery, E antigen positivity of the mother, and delayed administration of post-exposure prophylaxis to the infant at birth. Some other reasons to consider that could have contributed to an infant contracting hepatitis B are delayed administration of the hepatitis B series and blood-to-membrane exposure from a hepatitis B infected household contact or caregiver. Let us examine each. Let's consider the hepatitis B viral load of the mother during pregnancy and at birth. Nora's mom, Mary, was never tested for hepatitis B viral load in her pregnancy. Therefore, it is difficult to know whether the virus was at high levels during her pregnancy period. The CDC and American Association for Study of Liver Diseases now recommends that each mother get tested for hepatitis B viral DNA to guide the use of maternal antiviral therapy during pregnancy. Testing is indicated by 28 to 32 weeks gestation to evaluate the need for antiviral therapy. Tron, in his 2016 published article, Hepatitis B in Pregnancy, from the Infectious Disease Society of America, takes note of the quantitative hepatitis B virus DNA being performed at a baseline marker and at 28 to 32 weeks gestation. Viral load levels greater than 200,000 international units per milliliter have been associated with increased rate of maternal-child transmission of hepatitis B. Testing at 28 to 32 weeks gestation allows time for antiviral therapy to lower the viral load for the mother at time of delivery. Now let's consider the factor of hepatitis B E antigen positivity of the mother during pregnancy and at birth. Mary and her baby may have benefited from a viral load evaluation early in the pregnancy, and at time the labs were ordered at 36 weeks. Instead, a hepatitis profile was ordered at 36-week visit, which did not give any new information about the hepatitis status. What might have been helpful in the absence of ordering hepatitis B viral DNA would be the hepatitis B profile, which includes serological markers for hepatitis B, rather than a hepatitis profile, which gives a screening of hepatitis A, B, and C. The hepatitis B profile includes the E antigen status. The presence of E antigen indicates hepatitis B viral replication and high infectivity and might have indicated a high hepatitis B viral load. One of the other factors contributing to increased perinatal exposure of hepatitis B is delayed post-exposure prophylaxis. Baby Nora received hepatitis B vaccine and hepatitis B immune globulin within 12 hours of birth. She did not have a delay in post-exposure prophylaxis, so this was not a contributing factor to her contracting hepatitis B. Next is the possible factor of delayed immunoprophylaxis. Baby Nora also received timely well baby appointments with all vaccines administered on schedule. This was not a contributing factor to her contracting hepatitis B. Let's consider close contact with a hepatitis B infected person. If a caregiver of baby Nora was infected with the hepatitis B virus, there still would have to be a unique opportunity to transmit the virus through mucosal membranes. While possible, it is unlikely that this happened. Baby Nora also had timely chemoprophylaxis. The hepatitis B vaccine has a 25% effectiveness rate after the first dose and 65% effectiveness rate after the second dose and a 95% effectiveness rate with all 3 doses administered. Theoretically, transmission from an infected caregiver is possible, but the least likely. Now, let us recap the recommended prenatal management of a hepatitis B infected mother. Screening of all pregnant women for hepatitis B surface antigen in each pregnancy, even if known as hepatitis B surface antigen positive before. The DC Municipal Regulation 207.1A outlines management of each prenatal client and states blood sampling during the first prenatal visit for hepatitis B surface antigen. This also helps DC Health identify cases prenatally through coded prenatal panels. The hepatitis B surface antigen test is typically included in a prenatal panel if ordered. Baseline hepatitis B virus DNA and hepatitis B profile. While a baseline DNA is optional, it could be an early indication of the need for antiviral therapy. A hepatitis B profile may indicate where in the infectious process a mother stands and her level of infectivity with hepatitis B E antigen evaluation. Some antiviral medicines have been shown to have an impact on E antigen positivity with administration. If at this point the mother meets treatment criteria according to the adult treatment guidelines, treatment with a recommended antiviral can be started. Hepatitis B DNA at 28 to 32 weeks gestation to evaluate the need for antiviral therapy before delivery. Antiviral therapy is recommended if the mother's hepatitis B DNA reaches a level of greater than 200,000 international units per milliliter. And finally, hepatitis B surface antigen testing of L&D admitted women whose labs are not available, who have not had prenatal care or are of unknown hepatitis B surface antigen status. The DC Municipal Regulation 207.1b outlines management of women of unknown hepatitis B surface antigen status at time of delivery. Along with testing for HIV, syphilis, and rubella, the hepatitis B surface antigen test should not be ignored and is an important component of the communicable disease profile. While we may never know with certainty how baby Nora became infected with the hepatitis B virus, as practitioners, we can do much to lessen the chances of any other baby becoming infected. With routine testing of all pregnant women for hepatitis B surface antigen, hepatitis B viral DNA testing at 28 to 32 weeks for those who are hepatitis B surface antigen positive, post-exposure prophylaxis given within 12 hours of birth, and timely vaccination of the hepatitis B series, the District of Columbia can hope to achieve a 0% perinatal transmission of hepatitis B in each of the coming years. Thank you for listening.